Our program is being sponsored by Rehab Without Walls, Neuro Solutions, and Janet Keith, our presenter, works with that organization. She's an occupational therapist and certified case manager with more than 25 years experience in neurorehabilitation and case management. She graduated summa cum laude from the University of New Hampshire in 1996 with a major in occupational therapy and a minor in psychology. Her career trajectory includes positions as outpatient occupational therapist, director of rehab, a clinical evaluator, a director of admissions, and rehab hospital brain injury unit case manager. Her current role as the community relations manager for Rehab Without Walls home and community program in Maine provides her with the opportunity to screen patients, interface with funders, provide advocacy, and build a vital service model in the continuum of community-based rehabilitation for neurological, complex, orthopedic, and post-intensive care patients. Janet is a member of the Brain Injury Association of Maine, America Conference Committee, and values providing educational opportunities to professionals, survivors, and their family members. Please join me in welcoming Janet Keith.
There we go. Can everybody hear me?
Yeah, we can hear you, Janet.
We can hear you. Janet, you want to do your marketing slides first before you go into it?
Sure, sure. Thanks so much, Maureen and Nancy, for that introduction and for agreeing that this is a great topic for people to learn about. I am thrilled to be here tonight. It's been hard marketing and educating folks from a distance, and so this is my first live webinar, so I'm really excited about that. Rehab Without Walls is a really unique company. They are looking across the country at the needs in the continuum of care for patients that have both neurological, orthopedic, and complex injuries that will benefit from a more specialized and dense rehabilitation model than traditional models provide. And so this model has moved across the country. Sometimes they open home and community-based programs like the one we operate in Maine. Sometimes they open more than one home and community and outpatient programs, and there are also post-acute residential programs as well. The company is owned by Bright Spring, which owns many other home care agencies, hospice agencies, support services for patients and families with developmental disability challenges. And so it's really a company that's sort of striving to be one of the best human services agencies in the country. And I can say that I've been here about a year now. I've seen the growth potential that is here in Maine. We're hoping to expand that outside of New England. And the mission is always to help patients recover and to support their families in that process. So our caseloads are not as high as traditional outpatient and home care agencies. We're looking for that comprehensive interdisciplinary model that's going to bring somebody from leaving a hospital, struggling with post-concussion syndrome, leaving a skilled nursing facility, back into the roles that they value in their lives and the functional tasks that they really value and want to be able to do on their own. So that's a little bit about Rehab Without Walls. I'm going to see if I can get the second page to come up here. There we go. Rehab Without Walls has its information on www.rehabwithoutwalls.com. You can anytime reach out to community relations managers at any of those sites I mentioned for more information. We are a CARF accredited agency nationally, and so that brings us sort of a standard within the provision of service community that other traditional models sometimes don't possess. So we're very proud of being CARF accredited across the country. And right now, Rehab Without Walls has expanded our services from the border in Maine up to the about 15 to 20 miles around the city centers of Bath, Brunswick, and Lewiston, Auburn. And then we also have a patient all the way out in Oxford, Maine right now, and we have patients just over the border in Elliott and York as well. So that is a little bit about Rehab Without Walls. Let me see if I can get the first slide to come up here.
I have to change the sharing.
Okay.
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 This is a process. All right, let me see. Hold on 1 second. Okay, Janet, you need to request.
Are we there?
I think you are. Yep, it's controlling the screen. Good luck.
All right, I clicked. I'm waiting for it to come up. Here we go. So the objectives that were part of this presentation are to define home and community rehabilitation and how that's different from traditional models and levels of care, to talk about some key concepts of neurorehabilitation, to discuss the types of patients who benefit from the home and community model, to talk about why the interdisciplinary approach and the role of various disciplines involved is so important to the outcomes for the patient and the family, and then to look at those outcomes and how home and community can provide a different trajectory for patients as they continue to recover from these injuries. And I apologize, my slides take a little bit of time to switch over. There we go. So home and community rehabilitation is really a comprehensive model of care in the patient's own familiar environments, in their homes, at their community-based gyms, if that's a goal that they have to return to, in their workplaces, you know, going somewhere with their family members, that's a familiar place for them, to go anywhere in the community that they would typically access. And so part of the uniqueness of this model is there's no need to guess about the generalization of skill function from a home care model where someone's only allowed a 1-hour visit and then you're wondering if the patient's going to be safe or if they can implement the strategies that you taught them, or from an outpatient setting where you're trying to make as similar of an environment of treatment as possible to the patient's home setting. So this is really about treating people in vivo in their real life in the functional skills, in the functional skill areas that are important to them. So the history of this home and community rehab model, it's really an alternative to facility-based rehabilitation. Those rehabilitation stays are getting shorter and shorter. And we're able to support someone with a more dense model of rehabilitation to save on those acute hospital, rehab hospital, skilled nursing facility costs, and to keep patients safe while they're undergoing those transitions. And then it's also looking at the length of stay that patients now have. With the hospitals right now, with the COVID pandemic and things so pressed to serve more and more people, the lengths of stay are getting shorter for patients who would have been there a bit longer time, who have a brain injury, a spinal cord injury, or who have post-COVID symptoms. Even complex orthopedic patients might not be able to get into an acute rehab setting just because of the bed crunch that's sort of all over the country at the present time. And the home and community-based model is really based on a concept of ecological validity. How is the interventions that each treatment team member is providing relevant to that person's daily life? How are they going to take the skills that you're either remediating or compensating for and transition those into implementation into the areas that they need assistance in? So I think this whole model really supports people when things get difficult. You're not always seeing people after they're rested in their first hour of therapy. You're seeing people at the end of the day when they're struggling to figure out how to get through the day. You're seeing someone in a community who's getting overwhelmed by the noise and the lights or the sensory input that they're getting on a street. And you're able to help them through those situations. So when life is happening in this study that they did with Shard, Caffrey, and Powell, it's looking at how you're treating function as the person goes through their daily life. And why is this important? It's important because if you went to an outpatient clinic and you had a brain injury and someone's sitting with you in a quiet room with the door closed where the phone doesn't ring and the dog doesn't run in and your husband doesn't come in and start talking as he's getting home from work, it's a lot easier to implement skill sets when you're learning in such a controlled environment. But when you're learning in the environment of life, we all know that those environments are not always well controlled. It's also teaching people how to gain control when they have those challenges, how to educate the family about what someone needs, who sometimes has a more invisible injury, where they may be physically doing well, but cognitively, perceptually, and visually, there's a lot of challenges. The functional carryover is amazing to witness because you might need to go 3 times to help someone be able to cook a 3-item meal or a 2-item meal. And then you find their success path and you follow that path. You're not trying to have them do things that are too difficult for them and having them fail and come back to you and say they weren't successful. You're able to show them their successes each week as treatment goes on. And you're also able to stage their learning environment, and the learning environment is open to be their leisure skills at home. You know, if they did yard work at home, if they want to walk on an even ground at home, if they want to try and get back on a bicycle, or if they want to try and juggle their kids' schedules and they can't imagine doing that, you're teaching them the skill sets to be successful with those tasks. And they're optimized because everything is how they remember it. All the items in their kitchen are where they know they are. You're cooking things that are familiar to them. You're problem solving self-care in their own bathroom. You're helping them manage when the kids are home after school and how to try and set themselves up for a successful hours with their children at home. So the interdisciplinary model means that there's overlapping roles and functions amongst the team members. There's not a silo of speech therapy only does these tasks, OT only does these, and PT only does these. We all operate within the realms of our licensure, but what I see is our teams able to identify quickly the areas of challenge, and then each person's treatment builds on the one that was prior to them. There's a lot of communication amongst the teams. There's a common assessment that happens where they all talk to each other. They have common family and team meetings with both the patients, the families, and case managers, workers' comp case managers join those meetings. Sometimes the physicians and other treating clinicians will join those meetings, and everybody has the responsibility for that collaboration. It's not just up to one person who's coordinating the case, it's up to every single person on the team. And a person-centered approach to rehab is what Rehab Without Walls is about. There's a pre-admission screen that happens before a patient is enrolled in our services, where we interview both they and the family, either in person, virtually, or sometimes via phone. And we talk to them about where their challenges are. We talk to them about what goals they have. What are the tasks they want to be able to do? How quickly do they feel they want to achieve these tasks? Sometimes we can provide a very dense rehab model, and for some patients that doesn't work up front because they have to work up to the cognitive and physical endurance to be able to do a more dense model. And it includes a willingness to adapt rather quickly to what's happening in their lives. Patients go on vacation, their family members get sick. You know, sometimes they have to miss a session or two. Sometimes they want more sessions in a week to prepare to go to a wedding and be successful with ambulation on this outdoor ground, or to be able to prepare for a doctor's appointment that they're going to. And so you're relying on the clinical expertise and the relationship that you have with that person and their family. Some of the families, if the patient themselves is not able to drive, you know, talking a lot about the rehabilitation goals for themselves, you're relying on the family members to be able to do that. And we're really listening and building trust in the things that are most meaningful to the patient. I think that's why the outcomes in these types of programs really speak to how invested the patients and families are in changing their function, because they're working on things, tasks, and implementing interventions so that they can do the things that are most important to them. And who doesn't want to be able to stay home alone? You know, if that's a goal, we work on those goals. It might take months of time for someone to be able to stay home alone for 4 hours or 8 hours, but that's the goal. And that's what the team is going to continue to work on. So these are just a few points about what we just talked about. The person-centered approach means that you're considering all those 5 outer circles as you are treating the patient. And it's important that you touch upon every one in each treatment session that you're doing. The needs of patients and their families change over time. You can't always be the one to solve the problems for the patient and family as they're going through the recovery process, but you can encourage them and give them the tools to be successful and feel supported. And that person's quality of life and the quality of life of other family members are really important to this process. As you support people and you give them that quality of life, you really see amazing things happening with their emotional, how they feel about themselves and how the family member feels about themselves, and how they can both start to resume former life roles and responsibilities. And neurorehabilitation is really based on an integrated interdisciplinary model, which gets to all the systems that have been affected by the injury. And the goal of any neurorehabilitation program is to allow someone to function as independently as possible. And it's amazing to watch the safety recommendations that our teams are giving to patients and families about the weaning away of supervision, the weaning away of cueing strategies, and how they're teaching patients to be more independent while giving the family some confidence that the patient can stay home alone for 2 hours. The patient can ride their bike on a familiar path in their neighborhood. The patient's able to walk to the mailbox and get the mail on their own and come back. So whatever the goals are, it's weaning away those supports while you're supporting the patient and family. That makes home and community, I think, a little bit different than traditional models. And we talked a little bit about, you're always looking at restoring function. Sometimes restoring function means using compensation at the beginning and then weaning that away. It may mean setting up the environment so someone can be successful. Sometimes family members don't realize that someone with a brain injury can't go out to the grocery store 3 days after they leave the hospital because they're going to get overwhelmed and they're not going to be successful in even accompanying someone to the grocery store. So it's teaching the families and the patients where they're the most successful with task performance, and then watching that over time and giving them more confidence over time to try more difficult things, and to support someone in the goals that they have that may have seemed far-reaching at the initial admission, but that may actually be able to be achieved by the time someone's closer to discharge. So a lot of neuro rehab programs have traditionally been based in a medical model of care. That's how funders look at them. That's how, in transitions of care, that's how many professionals looking at what model fits a patient's needs are looking at making recommendations. And those include inpatient rehab units, residential neuro rehab facilities, day treatment programs, and outpatient clinics. And while that model remains the predominant model of how we think about transitions of care, hospitalizations are getting shorter. Skilled nursing facilities don't have the capacity to admit patients for rehabilitation services only. Somebody has to have a high nursing need to get into a skilled nursing facility. And it's really stressed the importance of these home and community-based models. The diagnoses served are pretty wide and varied. Any type of traumatic or acquired brain injury, post-concussion syndrome, stroke, MS, Parkinson's. We've had some ALS patients across the country, many patients with spinal cord injury, spinal tumor removal, along with the oncology patients that have brain tumor removal as well, and then any type of progressive neurological disease. We're also treating multi-trauma patients, and we've had an uptick of post-COVID patients, the post-intensive care patients, who really, their endurance and their ability, their strength has been so affected by having that COVID trajectory, that we're finding that the more frequent therapy within the amount of time they can sustain is very good for them versus having an hour of therapy, or even for them trying to go to outpatient therapy. It's really creating a comprehensive model that can build over time as their endurance for function builds. So when you're thinking about patients who can benefit from home and community rehab, when I say intensive rehab, some of our patients are only getting 6 hours a week, some 10, some 16, some 26. So the amount of hours can vary, but the hours are not limited to an hour. So if someone benefits from a 2.5-hour session a couple times a week when they're in function and doing tasks, we're able to sort of tailor their rehab program to exactly what their physical, cognitive, and support needs are. Usually we don't do single discipline rehab, but we have done some post-concussive patient tune-ups where they only needed OT for strategies or only needed speech therapy. And we've done some of those types of single service patients, or everyone else will discharge as the program, as they complete their goals within those parts of the program, and somebody might stay on with occupational therapy if they're going to move to another apartment, and all they need is for someone to make sure they're functional, doing functional tasks in their apartment. Somebody has to have family and other supports at home, and you'd be surprised at how many families are willing to take someone home when they know there's going to be a more dense rehab model provided to them. And Rehab Without Walls has programs for both children and adults. In Maine, we have a pediatric and adult program. And we have patients at all different functioning levels. We've had patients referred with new strokes who have dementia. We've had really high level patients, an anesthesiologist who had a stroke and wanted to go back to work as soon as possible. Everybody has questions about the payment sources. So each state, their commercial plans look at Rehab Without Walls home and community programs individually. So across the country, we have many contracts in many different states, but I would say each state does not mirror another state. We have a national contract with Aetna. We've received many single case agreements in Maine with Anthem Blue Cross Blue Shield of Maine, out-of-state Blue Cross plans, Cigna, one approval from Harvard Pilgrim, and we've worked with all types of workers' compensation adjusters and insurers, and third-party administrators. We have contracts with Corbell, and Home Care Connect and different third-party administrators. And believe it or not, some people are choosing to private pay for our services. Sometimes they've had challenging diagnosis and they've tried the traditional medical models, and those have not worked for them. We had a woman who came out of Brigham and Women's Hospital with a pretty complex functional neurological diagnosis. She had tried home care, she had tried outpatient, and her family really knew she could be successful, I think, with a dense non-medical model, and her outcomes were really wonderful. She was in a wheelchair when we started, and she was walking in her neighborhood by the time Rehab Without Walls ended services with her. And they private paid because they knew that that was going to be, I think, the most successful way for her to receive rehabilitation services.
Janet, we have a couple of questions.
Sure.
We have a question. Does Rehab Without Walls accept public programs like Medicare or Mass Health?
I was just getting to that.
Okay.
Whoops.
And the other question you're probably getting to, your case rate, the daily rate, and do the disciplines bill individually or as a team?
Sure. The slide just changed there when Nancy came on, and this presentation was done out in California, and that's why it said Medi-Cal and different public funding sources in California. Medicare does not fund this model. Medicare only believes in homebound status with OASIS billing with the CPT codes that have been assigned to home care therapy and nursing interventions. So Medicare and Medicare Advantage plans and Medigap plans will not fund this type of rehabilitation model. Am I hopeful that someday that will change? I am, because I think the need is there for people. We have young, sometimes patients with developmental challenges who then have an acquired neurological injury at age 25, and it would be great to serve those patients, but Medicare is their primary funder. And again, it's only the medical model options that are offered under Medicare. Medicaid plans often mimic what CMS allows them to fund. And so that's also governed by the Centers for Medicare and Medicaid Services. So I think across the country, there are some Medicaid programs that might fund this model, but I think it's probably rare. Most of these models, they want them to fund them out of a brain injury waiver, and the waiver services sometimes take between 1 and 3 years to come on board. And then there are already waiver-based providers that are typically day treatment programs or their residential homes providing rehabilitation in the homes. So those two funding options are really not possible right now. In Maine, we have had conversations with Maine Care. We would love to serve some of the newly injured Maine Care folks. The cost of running this program is partly you're paying one-way transportation for a therapist, and you're also paying them, you know, to drive sometimes so many miles to someone's home. So the rates within those public funding mechanisms in Medicaid would have to be reflective of the cost it would take us to get to someone's home or take them to the community. What was that second question, Nancy?
She was asking about the rates and the costs.
Sure, I can talk about that a little bit closer to the end. We can look at transitioning someone to home. We can look at what equipment needs they have, how their home is set up, how to establish a structure and routine. We hear many family members complain that when they first take someone home with a brain or spinal cord injury, they're not motivated to get up. They've been in the hospital on the hospital schedule for a long time. They want to get away from that. They just want to stay in bed watching television, and sometimes not engaging in the most productive things that will continue their recovery. We really work very closely with the teams at any hospital, physician's office. We want to know what they know about the patient. Many times we're going into the hospital or skilled nursing facility to screen new patients. Sometimes we're going directly to their homes to screen them and meeting with the patient and their families. We've had some workers' comp entities that had really complex injuries coming home to a home that they weren't sure would be set up for someone, and we can send a clinician in to sort of do a home assessment and make sure everything's set up for the person when they're coming home, if they're coming home at a wheelchair level, just to make sure that the house is ready for them to come home. Hang on, I'm not. So it's also about caregiver training. We can provide, I have had some cases recently where the family members, because of COVID, didn't want to go to the hospital and participate in caregiver training. And we're able to carry that over the next day after someone gets home to make sure they have what they need. Caregivers sometimes don't remember everything they're taught. Caregivers can be shown how to use a Hoyer lift 3 times in the hospital, but then in real life, when the person has to quickly get on a commode chair and roll over the toilet, it becomes a whole different scenario with what they were taught as to how they're trying to move someone and be safe doing it. And so, sometimes we can help people problem solve the most efficient and safe ways to care for their loved one at home with the equipment that was provided. And as we all know, COVID-19 is impacting family visits, where families used to be able to sometimes stay in the hospital with someone or visit daily and watch the therapy day to day and build relationships with the therapist and really see some of the problems that might arise in transfers or in care. And sometimes that's just not possible right now. I love these next 2 slides because home and community can really be the puzzle piece that fits across all levels of someone's recovery. So sometimes we come in right after acute rehab. Sometimes we come in if someone can't get to acute rehab. If someone has a one-to-one in a hospital setting, their family wants to take them home and they can't wean the one-to-one at the hospital, home and community with that dense model can be really helpful. Sometimes we come in either before or after home health. It kind of depends on the patient's needs. Sometimes we work in conjunction with home health, where they're providing the nursing services and we're providing the rehab services. Residentially, we can wean someone away from the need to be in a residential setting if we can bring them home and then show their family that they really can be functional in a home setting. And sometimes outpatient right now, I mean, a lot of the outpatient clinics are closed to new admissions. There's an inundation of people, I think, trying to get to both home health care and outpatient, especially post-hospitalization. And home and community can really fit that niche. We're working really well in conjunction with some outpatient centers who have waiting lists. If we can help someone until they can get into the center, that's a wonderful thing, because we're all just about, being able to really help the patients recover and support their families in the process and not to be on a long waiting list.
Janet, we have another question.
Sure.
Are there any resources for free care versus private pay?
Right now, there are no resources for free care for these types of programs. I think that may be coming over time. The programs are run on a pretty tight budget as far as, the therapists are employed per diem. Some places have full-time therapists. We have right now 2 full-time therapists, PT and OT, that have over 10 years of neuro experience. And so when you're looking at finding those types of clinicians who are really creative in these roles and really skilled in these roles, there's not options for free care at the present time. And this slide just talks a little bit about how home and community can fit in the continuum of care. And you can see that there's many places where these home and community programs can fit in. I want to talk a little bit about a very unique case we had referred to us for a woman who had been in a locked dementia facility after encephalopathy, brain injury. And she would not have been safe anyplace else, but over time, her brain recovered. She regained more skills. They tried to bring a home care model in to really make a prediction about whether she could leave that facility or not. But I think they were never able to take her out in the community and see how safe she was. And so her physician's office and the nurse case manager and social worker at the physician's office were feeling very strongly that they wanted to see if this patient was able to live in a less restrictive level of care. And this person had been there for about a year at this point in time. And she had really shut down, and she didn't want to engage with the staff or the other residents there or the therapists that were coming in, because she was engaging, but she didn't see how engaging with them was going to get her to the end goal of being able to leave that facility. And so we worked for a long time with her family. We talked about a lot of different options for them. We did some assessments with her when she was in the dementia facility. And then those assessments led to a assisted living transition level of care. And then they eventually led to her having her own apartment with intermittent check-ins from caregivers. And so that's just an example of how this program can shift itself and meet the needs of somebody at many different levels of care, at many different levels of their recovery process. And so it's never, I would say, don't ever hesitate to call and just say, can you handle this patient? If someone has too high of nursing needs and they don't have a funder who's going to split the nursing needs with our rehab team, then we're going to defer to a home health model. Rehab Without Walls does not have nursing as part of its clinical offerings, and we can work in conjunction with a home health agency with nursing if the funder is able to approve that. So here's a little bit about the difference between home and community and home health. So there's a real neuro specialization, a complex orthopedic specialization. The intensity of services is much different than a home care agency, and there is no homebound status. So that opens up really treating someone in function across many different types of environments. And in outpatient, you have this, you have a team, but sometimes that team doesn't meet about you outside of your therapy session. So you're getting a single service of this person and then of the next clinician and then the next one. And so there's a really big coordination of services with home and community. And it's really in real life. You're not simulating anything. You're not guessing about someone's safety to be in a community setting or at home or to shower alone or to walk across the room alone. You're really being able to see and predict success for people as they continue to recover. There's also clinical coordination that's part of this model, and some funders require the clinical coordination to be separate, and some want a clinician to do the clinical coordination. So some of our clinicians have been trained to do that clinical coordination piece if the funder drives that part of the model. If they already have a case manager at their funding, source, then sometimes they don't want to feel like there's duplication of services. I would say all families and all patients need continued education as they go home. I don't think there's ever a patient who's totally prepared for everything, every challenge that's going to happen to them in the months that are following significant change in their function. And, some patients have really low level goals where they just want to be able to go to the bathroom on their own, and that's their major goal. But then as you're treating them, the goals change. You're giving them the psychosocial supports. You're educating the family about what it's like to, be a caregiver of someone with a cognitive or a physical challenge, and then how to wean away. Families are afraid to wean away and not to cue somebody 30 times about being safe, or not to be able to be there when they're going to the bathroom or taking a shower. But you're able to show them sort of in vivo over time that someone really is safe to do something. We can also make predictions about return to driving. We monitor the nursing needs that someone may have. If someone's supposed to have INRs drawn, we make sure that those are done. We're communicating with the PCP offices. PTs can do wound care within the scope of their license and monitor a wound that someone may have. And we're not overstepping the scope of our license. If someone has a G2 pump and they're leaving a hospital setting and they also have oxygen needs, that's someone who really is not ready for home and community yet. And they need those nursing supports over time, maybe until they're able to just engage in a rehab program and not need that nursing oversight. In different home and community programs across the country, some of them have all of these clinical options and some only have some. Here in Maine, we do have clinical coordination. We have a consulting neuropsychologist. We have OT-PT speech. And we don't have those other disciplines that are listed here. Those other disciplines are frequently funded by special programs in Michigan and Texas that have auto no fault funding. And so I think if someone's in this home and community model, under the funding mechanisms that we have, it would need to be a reimbursable service, but we would be more than happy to help someone find a dietitian or receive counseling in the community. You know what, Maureen, my clicker is no longer working. I apologize about this, unless there's a big lag going on. I've tried a couple of times. Let me get to the other question while I'm waiting to see if it's just a slow internet connection that's going to switch the slides. Rehab Without Walls has a published rate. And we also have many contracts across the country that hold those contracted rates. So if someone's thinking about private paying, we can negotiate with them about a private pay rate. Many of our commercial funders have established rates with us in single case agreements. And I think if someone wants the private pay rates or the published rate, I would appreciate it if you would reach out to me directly. We have rates with Corvell. We've had contracts with Liberty Mutual, with the Wyndham Group. And so there's negotiations that our program manager does with each one of our funding sources to establish the rates. Aetna is the only one where we have a commercially funded insurer where we have a contracted rate with them. And just a little bit about clinical coordination. They are the funnel of all communication between the patient, the family, and the team. We do patient-centered progress reports from the clinical documentation. We make sure we have doctor's orders. We're communicating with the physiatrists, the orthopedists, the prosthetists that are treating our patients. We're facilitating referrals for equipment and any follow-up outpatient therapy. And sometimes we're also doing therapy in conjunction with other rehab entities if the funder approves of that. I think you're going to have to operate it from now on, Maureen, because I'm not getting any clicks going here.
Okay, just tell me when to advance.
Okay, sorry about that. These are just some of the tasks that PT, OT, and speech are able to do. I'm not going to go through all of them. But I do think that the transition from becoming independent at home and independent in the community is definitely something that's facilitated all of the time. And you may be facilitating someone with a high-level spinal cord injury being able to operate their power wheelchair in a community setting. You may be facilitating someone with a brain injury being able to negotiate going to their doctor's appointments. We're allowed to take the patients in our vehicles if we have the appropriate type of transportation with them, or we can have family members bring them out if they have adapted vans and things like that, and we can meet them in community settings. Next. Right now, Rehab Without Walls in Maine does not have licensed clinical social work. And that is something that we're looking to be able to have. So we are referring our folks out to outpatient services for that right now. I would say that the clinical coordination piece can cover if someone needs access to community resources. Also, a lot of our clinicians are very well versed in the resources available to someone, as are Christine Martin and I, who've worked in Maine in this neurorehabilitation field for a long time. Part of my role as a community relations manager is to know about those resources and be able to help people find resources that we're not able to help sometimes, and to also expand upon the resources for our patients. And we do have a consulting neuropsychologist who can do testing if it's appropriate and approved by the funder. And then he can also consult on some of the more difficult cases that we have. Next. I'm trying to keep track of the time here. Can you skip this one? I didn't talk about co-treatments, but a lot of our PTs and OTs, or OT and speech therapists, are co-treating patients. As part of this interdisciplinary model, we can work together to take someone to a workplace, to simulate a work environment here in our office. The average number of hours per week that someone is served is 14. But as I said before, we can serve someone for maybe as little as 4 to 6 hours with specialized needs that they may have, and we can go all the way up to 26 hours. And the treatment sessions sometimes are really productive when they're longer than an hour. Next. So we're always talking to the patients about what their goals are. And here are some examples of some goals that patients have. I would say that OT and speech sometimes are doing medication management reminders. We're using iPads and the phones that you wear on your wrist. We're setting up special cognitive activities for people on their iPads and their computers. We're going to schools for our pediatric patients and working with the special ed departments in order to be able to make that comprehensive and supported transition back to school for kids. Next. So things are different at home because of some of these reasons. You know, the roles that someone has changes when they go home. There's different family structures that people have. Sometimes the architecture isn't what someone imagined it would be like when they're bringing someone home in a wheelchair or on a walker or with a prosthetic. So these are some of the reasons why it's good to have these home-based programs. Next. We use the Mayo Portland Adaptability Inventory as our outcome measures for our all our patients except for spinal cord injury. For spinal cord injury, we use Craig's chart program, and it measures someone's abilities, their adjustment, and their participation, and it's done at admission and at discharge and at 3 months and 1 year. Next. And here are some of the outcomes. Now, Rehab Without Walls in Maine has only been open for a year, so we're getting ready to calculate our first year of outcomes, and these are from our Bay Area program over a 2-year time span. And so when the ratings go down, that means that patients are getting better. They're needing less guidance and assistance. Next. I think we can go to the next one. This is just about the Craig chart scores. We treat a lot of patients with spinal cord injury, and here are some of the outcomes of the Bay Area spinal cord injury patients on the chart scores for the Craig assessment. Next. We also do a supervision rating scale so that we're really looking at when does someone transition to less than full-time supervision? Is someone able to live alone? Next. And so here are some of the outcome scores in relation to that. You can see that the percentage of patients upon their admission that can be independent for more than 8 hours is like 16%. And then by discharge, that is 63%. And then over time, that remains at about 55%. Next. So here are some of the advantages of a home and community rehabilitation program. I would say that the outcomes are more durable, that the goals can be achieved more quickly because you're doing a more consistent and dense level of clinical intervention with people. You're also having a lot of communication with the patient and the family. You can figure out what the barriers and supports are. You can figure out if the patient's mother said she was going to support him, but then she's not doing that when he's at home, and how do you problem solve that problem? And you're also using their natural environment right away to eliminate any barriers to their improved function. Next. So here is my contact information. Please feel free to reach out to me via email or via phone with any of your questions. I did include our national map at the end of this presentation. And you know, those of you that are case managing in hospitals, you always come across patients that are from different states, but they're in your state when something happens. Please feel free to reach out to me about our programs across the country. I can connect you with the community relations managers in California and Arizona, Michigan, Texas, Florida, wherever they may be returning to, Georgia, South Carolina. And I would be more than happy to help you problem solve what services are available to them in their area. Next. Here is our national map. As you can see, Maine has the only from Virginia up, we're the only home and community and outpatient programs, residential programs that Rehab Without Walls operates. We're hoping to expand into New Hampshire in mid-2022. We're always looking to expand programs in different states. This program in Maine has grown by leaps and bounds, and Christine Martin, our program manager, and I are very proud of all the clinicians and the amazing outcomes we've had with our patients. Any questions? Are we good, Nance?
Yeah, we're good. There aren't any other questions.
Okay, great. Well, thank you all for taking time out of your pre-holiday planning to join the Case Management Society of New England and myself for this presentation. Thank you all so much, and have a happy holiday.